for the masterclass series under the aegis of AOGD Endoscopy Committee and IAG Delhi chapter. Today we are learning about vaginoplasty, rejuvenation to reconstruction from the stalwarts in the field. To start the program, I invite Dr. Kanika Jain to give the welcome address.
Thank you, Ankita.
Ma'am is chairperson. Ma'am, I'll introduce. Ma'am is chairperson Endoscopy Committee 2021 to 23. She was vice president AOGD 2020 to 21. She's senior consultant gynae endoscopic and robotic surgeon minimal access gynae unit Sir Gangaram Hospital, and executive member IAGE and joint secretary.
Ankita, enough.
Welcome, ma'am.
Thank you, Ankita. We are already late, and I, on behalf of the AOGD Committee of Endoscopy Committee and IAG Delhi chapter, I extend a warm welcome to you all. A very good evening. And today we've come up again with one of the masterclass series of our webinars, which is on a very relevant topic for the day. A girl without vagina is normally considered a taboo. So for her, it affects her social, psychological, sexual, physical health. So we have here stalwarts discussing how she can overcome this problem and how she can lead an active, normal life as far as possible. So we have Dr. Ritu, who has some emergency at home. So Dr. Hira would be presenting her presentation. And we have Dr. Hafiz, whom everybody knows, who would be discussing the various endoscopic treatment options for such girls. Then we have another topic, which is a very relevant topic, but it is usually subdued and not touched much, which is vaginal rejuvenation. So we have a stalwart, Dr. Ragini, who would be throwing some light on this. And without much ado, I would not hold on, and I would like to start the program. And before that, I would like to welcome Dr. Achla. And I would request ma'am to say a few words of encouragement to us. Dr. Achla is the president AOGD, and she's a senior consultant professor at Safdarjung Hospital. And I think she needs not much of an introduction beyond this. Everybody knows her beyond Delhi also. So ma'am, over to you.
Thank you, Kanika. And like always, another masterclass by the endoscopic committee. Very targeted approach you had this year, and really good. And vaginoplasty is something which has, over the years, from where it has gone many transitions, not only in the methods, but also in indications, I mean, when we were studying, it was only for when the vagina was absent or injured. But now we have, this transgender surgeries also, where vagina is being created for people who want to change their sex, and methods from, surgical method, which we do vaginally or abdominally, opening the abdomen, or now we have, laparoscopic methods, and many methods have been, invented, because when we are not perfect in something, that is one thing in which, many things will come. If we are perfect in one thing, then it stays. So still people are, trying to find out the best method for creating a vagina. And the other taboo topic, like you said, the vaginal rejuvenation, that also has been there. Surgical method have been there, and now we have minimally invasive method. Whether they are approved or not, still there is some issue about that can we use them or not use them. I think Ragini will throw light on them, and we will have, I think, wonderful videos from Dr. Hafiz Rahman as always. So and I think everybody is going to enjoy today's session. Thank you.
Ma'am, Kanika ma'am, you're muted.
So sorry, Ankita. So thank you, Dr. Achla ma'am, for those kind words of encouragement. And I would like to invite our next guest of honor, Dr. Malvika Sabharwal. Dr. Malvika is the Padma Shri awardee, and she's the Chief Department of Gynae at Jeevanmala Hospitals and Apollo Spectra Hospital. And she's the founder chairperson of the Delhi Society of Delhi chapter of AOGD. And she has been president of the Delhi Gynae Forum Central. So over to you, ma'am. Has Dr. Malvika joined back? She wants to join back again.
Actually, your subject, vaginoplasty to which touch all those various, where we started and where we are now forward to being covered by any chance background from
ma'am, your voice is breaking.
Anyway, I will probably, there is a disconnection. So moving ahead, I think one speakers, we are really listening. We're very much looking forward to hearing all the talks. And we also target take on the, because I had my share of starting the therapy plan. I would love to Hafiz as always comes out to the best. So I will not waste time coming in between the scientific program. Thank you very much, Kanika.
Thank you, ma'am. Thank you so much. And I would now like to invite Dr. Mala Srivastava, who's our next guest of honor. Dr. Mala is a very dear colleague of mine, and I have worked with her, and we had a very good team as AOGD last year. And she's been past president of the AOGD. She's a senior consultant and Professor Gripmar at Sir Gangaram Hospital. And she has a lot of awards to her credit, and she's the ICOG Governing Council member, Zola chairperson of the ISOPAP, and she's been doing lots and lots of academic activities, and she pulls us also through with her. So thank you, Dr. Mala. I would just like you to say a few words.
Thanks, Dr. Kanika, for your kind introduction. Good evening, everyone. It's my pleasure and privilege to be part of this e-learning on vaginoplasty, reconstruction to rejuvenation, organized by Endoscopy Committee and IAG Delhi chapter. I must congratulate Dr. Kanika, who has been really working hard for this masterclass, and her team, Dr. Sonia Nayak and Dr. Ankita Srivastava, for organizing this webinar on such an important topic. It's always a privilege to share a platform with Dr. Achla Batra and Dr. Malvika Madam. And today evening, we have galaxy of star speakers, Dr. Ritu Arya, Dr. Hira, Dr. Hafiz Rahman, and Dr. Ragini Agarwal for the scientific deliberation. We have the privilege to hear from the experienced senior consultants and discussants, Dr. Indu Chawla, Dr. Usha Kumar, Dr. Kanika Jain, Dr. Geeta Mendiratta, Dr. Sonia Nayak, and Dr. Swati Agarwal, who will give their expert comments on the topic. I'm sure all the delegates are going to highly benefit from today's scientific deliberation. Over to you, Dr. Kanika, for the scientific program, to carry on the scientific program.
Thank you, ma'am. So now I would like to introduce our stars of the day. That is the people behind this webinar, Dr. Sonia Nayak and Dr. Ankita. Dr. Sonia Nayak is director and unit head at Max Super Specialty Hospital, and she has been past editor of Fetal Medicine Society, executive member of Endometriosis Committee, AOGD, and she is a member of the Endoscopy Committee and a very precious member. She has been pivotal in organizing many of these webinars that we hold. Always supportive, very helpful, and we are lucky to have her with us. And another member, young member dynamic of our society is Dr. Ankita, who has really worked hard. Even during her vacation, she had been organizing the stuff, sitting from Leh, so I could see a few Leh Ladakh pictures and could discuss with her. So she is associate consultant in the Institute of Obs and Gynae at Gangaram Hospital. She's been web editor AOGD in 2021, and she's a member of our committee. So over to you, Dr. Sonia.
Thank you, Dr. Kanika. And it's been a very exciting topic to actually work upon. And mainly it's been worked upon by Ankita only. I joined in between. And so friends, we all know that there's a normal anatomic variation in female genitalia, which continues to remodel with pubertal development, childbirth, and menopause. So in conditions like pelvic prolapse, perineal tears, and delivery, congenital malformations, tumors, we know that the surgical correction is medically indicated. But now we've been hearing these terms like designer vaginoplasty, revirgination, which has created a wave in the community. Although the robust evidence is still not there for these techniques, but evidence is always created by experience. And we as gynecologists, we play a very important role in helping women to understand their anatomy, to respect their individual variation. So now we have designed the CME, which aims at making us understand the balance between our desire, between an indication and the outcome of vaginal reconstructive procedure. So we have stalwarts which are going to present their experience in conventional vaginoplasty, laparoscopic vaginoplasty, and vaginal regeneration or the designer vaginoplasty. So we begin with our first lecture on the conventional vaginoplasty.
Thank you, ma'am. As we begin the academic program, I welcome the experts and discussants for the session. Dr. Indu Chawla. Ma'am is professor, consultant, and ex-HOD at RML Hospital. She is executive committee member AOGD Narchi and executive committee member of IAGE Delhi chapter. Her areas of interest are gynae endoscopic surgery. Welcome, ma'am. Dr. Usha Kumar. Ma'am is principal consultant, gynae endoscopic and robotic surgeon, Max Smart Super Speciality Hospital, Saket, and she has performed more than 10,000 surgeries. Welcome, ma'am.
Thank you so much.
Welcome, ma'am. And Dr. Kanika Jain, our own chairperson, endoscopy committee. Welcome, ma'am. I request Dr. Indu Chawla to please introduce Dr. Ritu Arya and Dr. Hira.
Thanks, Kanika, Ankita, team IAG and team AOGD for giving me this opportunity to chair a very important session in which stalwarts like Dr. Hafiz Rahman are elaborating on the topic, and we'll be discussing both conventional vaginoplasty and laparoscopic vaginoplasty. Though we are shifting to laparoscopic vaginoplasty more and more, but I think conventional vaginoplasty still has a place for reasons like everybody is not a good laparoscopic surgeon. Laparoscope may not be available to all. And the oldies like us, we are still sticking to the older procedures, So to elaborate upon the topic, I think we have two very experienced persons, Dr. Ritu Mittal Arya and Dr. Hira. Dr. Ritu Mittal, I had the opportunity to work with her, I think about 20 years back. And she's a very diligent person. Now she's working as a senior consultant at Shoda Hospital, Ghaziabad. And her areas of interest are high risk antenatal and obstetric care. And the other speaker is Dr. Hira. She's a young budding gynecologist, very enthusiastic. And I have interacted with her a number of times. And she's a very enthusiastic surgeon, learner. She's working as a consultant in Max Smart Super Speciality Hospital. She'll be elaborating on conventional vaginoplasty. So without wasting much time, I'll hand over to Dr. Hira. So please, Dr. Hira, you can take over.
Good evening, everybody. Thank you, Dr. Indu, for a very nice and pleasant introduction. I really enjoyed it, and it boosted my confidence for the talk today. Seriously. Before I start my presentation, very good evening to respected teachers, seniors, colleagues, and my friends out there. So actually today I'm presenting on behalf of Dr. Ritu Mittal. As she has got some medical emergency at home, she is not able to join us. So today I'll be presenting her video, and I'll be presenting upon conventional vaginoplasty today. So videos which I'll be presenting are done by Dr. Ritu actually. So going to the presentation on conventional vaginoplasty. What is vaginoplasty? Creation of an artificial vaginal cavity in patients with congenital disorders of sex development, and most likely the cases which we encounter is vaginal agenesis. So before constructing a vagina, what are our aims? So it's not that we're just constructing a vagina and then leave it, but we should have a proper anatomical aim and a functional aim. So the anatomical aim should be that it should have perfect anatomical measurement of the vagina. That's the vaginal length should be of 8 centimeter with proper width allowing introduction of 2 fingers. It should be cosmetically acceptable with minimal morbidity and low maintenance. And what about the functional aim? The functional aim is that the patient should be able to have a satisfactory sexual intercourse. So there are various methods of vaginal reconstruction. I'll be talking about conventional vaginoplasty, and Sir Hafiz Rahman will be talking about laparoscopic vaginoplasty. So there are 2 methods. We have non-surgical and surgical. The ACOG recommends non-surgical methods as the first line treatment, wherein we use simple pressure, that the Frank's method, or the pressure from a bicycle stool like by Ingram. So today we'll be talking about the surgical methods. The surgical methods way back in 1938, Wharton created a vagina, but he just created a space between the bladder and the rectum and then left it. What happened was it later stenosed. And then Abe Mackindo, later in 1938, what they did was, after creating the vagina, they had inserted a split thickness skin graft onto the newly created vagina. Also, this procedure also had its own advantages and disadvantages, and further many modifications of the Mackindo's technique came, wherein instead of the split thickness graft, we started using the full thickness skin graft, the amnion, the buccal mucosa, peritoneum, bowel, and so on and so on. So today, the video which Dr. Ritu is presenting, she has used interseed as the adhesion barrier or the graft. Okay, so we have the surgical method where Mackindo's and the modified Mackindo's technique, the bowel vaginoplasty, and the surgical traction methods. So the main cases which we encounter is the vaginal agenesis, which happens due to the MRKH syndrome. What happens is the MRKH syndrome is a case of Mullerian agenesis. So it happens in 1 in 5,000 to 10,000 females. In this case, since the lower 1/3 of the vagina is formed from the urogenital sinus, these patients will have a small vaginal dimple, or a small perineal pouch can be seen. But because of the Mullerian agenesis, the upper 2/3 of the vagina and the uterus may be absent. But such patients will have normal secondary sexual characters, and they'll have a normal karyotype. Usually they present to us with primary amenorrhea, or even later they present after marriage, failure to have intercourse. That's how they present to the hospital. So before planning for a surgical case, first we evaluate the patient, wherein we do the local examination and look for the secondary sexual characters. We look for the vaginal dimple, etc. And also we do a per-rectal examination to feel for the uterus if the rudimentary horns are present or not. And then a karyotyping is done. And also ultrasound is also done to rule out other associated anomalies, ultrasound and MRI. Then routine investigation is done. And a counseling plays a very, very important role before going in for a vaginoplasty. As ma'am has already told in the starting of the session, not having vagina is a taboo. So the patient needs a lot of emotional counseling. It's not only that, after doing a vaginoplasty, we need a lot of patient compliance, wherein she has to keep putting dilators, vaginal dilators for at least a year. Only then the length and the width of the vagina remains patent. So we need a lot of patient counseling, psychological motivation, and we need her compliance. And when do you time the surgery? The timing is at least few months before marriage, or at least the child is, or even if the girl is of a reasonable age, wherein she understands what we are talking about and that she'll be compliant. So coming to the procedure, once the patient is in the operation theater, she's put in lithotomy position. Here, I'll be showing video done by Dr. Ritu, wherein here patient is put in lithotomy position. We identify the median raphe and the vaginal dimple. Here, Dr. Ritu has used two things. She has inflated the Foley's with methylene blue, and also a methylene blue, a gloved finger is introduced into the rectum, dipped in the methylene blue. And then adequate amount of saline or adrenaline is injected into the vaginal mucosa. And then a transverse incision is made at the vaginal vestibule. And then with blunt dissection, mainly blunt and sharp dissection, the space between the urethra and the bladder anteriorly and the rectum is opened gently, mainly with the fingers and peanuts. Here you can see Dr. Ritu is using her fingers and peanuts. And it's opened up to the peritoneal reflection. Okay, slowly, gently using the fingers, and then the median raphe is cut, small anterior retractor is introduced. So to prevent injury or even to detect injury at the earliest, what she has done is, she has put a Foley's bulb inflated with methylene blue, and also the assistant is putting a finger in the rectum, which is dipped in methylene blue, so that we can detect any injury at the earliest. So now here we can see she has made a very adequate normal space between the rectum and the bladder. Again, she's using, and here in this case, thorough hemostasis is very important because she'll be using intercede as the graft. Okay, here gently she's making the space. Mainly you can see she's using blunt dissection. Space between the urethra and bladder anteriorly and the rectum below, up to the reflection of the peritoneum. Yeah, now we can see she's made a good length vagina. She says it's almost 8 centimeters. Now here she's showing a video of how she's made the mold, the vaginal mold. Here she has used a surgical foam, okay, sterilized surgical foam over a suction tube. The suction tube is used actually to deflate the foam while putting inside the vagina, so that it fits inside the vagina snugly. So the negative pressure is created, the vacuum is created. So here she's tying it with silk, this foam, and then after measuring the proper length of around 10 centimeters, she's tying it with silk, tight and negative. It's rolled, actually the surgical foam is rolled over a suction tube, wherein multiple fenestrations are made to create vacuum. Okay. So now this is the conventional method, and this is the vaginal mold where we are making. Okay. So once the suction is created, she'll put a condom over it, and then that condom is tied with a black silk. Over the mold which is created, now she puts the interseed. Here, again, she's just taking the mold, introducing the condom over the formed mold. And then interseed is placed over this graft, and it's stitched over the graft, and then this mold is introduced into the space which is created between the bladder and the rectum. Okay, and this interseed, this is the mold with the interseed coating over it, and this actually what the interseed forms a coating between the mold. The interseed forms a coating between the mold and the graft. So earlier people used to use split thickness skin grafts, skin buccal mucosa, amnion, peritoneum, etc. Here Dr. Ritu has tried using the interseed. And then the cells of the newly created vagina has the pluripotent potential for the tissue differentiation, and it epithelializes nicely into the vaginal mucosa. After inserting the mold, few stay stitches are taken with Vicryl 2.0 and label stitches are kept to keep the mold in place. On the 5th post-op day, mold was removed after 5 days and good epithelialization was seen. Good epithelialization was seen and a good cavity, vaginal cavity was seen, wherein you can see she has introduced a broad cin speculum. And the length of the vagina was also measured. It was almost 8 centimeters and it was patent and nice. And then the patient was given this glass mold for home dilatation, which she was explained how to do it and what to do. This dilatation should continue for 1 to 1.5 years for the patient to make a fine and adequate vaginal space. Dilatation instructions given to the patient are the first 3 months she has to put the mold 3 times daily, at least 10 to 20 minutes each. And then after 3 months, if the patient is really compliant, even she can use a next size mold, which we provide them. And for the next 3 to 6 months, she can put the mold at least once per day for 10 minutes. And then after 6 months, again, she should start putting the mold 2 to 3 times per week for 10 minutes each. In between, after 3 months of the procedure, the patient can undergo sexual activity. And this vaginal dilatation, self-vaginal dilatation should continue for at least one year. So here the patient counseling is very, very important. Otherwise, the whole work, the vagina may get stenosed if it's not properly dilated or if she does not start sexual activity after 3 months. So complications, as we all know, the immediate complications are bleeding, infection, skin or clitoral necrosis, suture line dehiscence, or urinary retention. And also, if the vaginal mold does not fit properly, or if it does not give a uniform pressure, there are chances of fistula formation. And also during the procedure, there are high chance of injury to the rectum or the bladder. And the other third complication is the vaginal stenosis, which happens if the patient is not very compliant and if they do not do proper dilatation. The first surgery done has the best chance of success. So this we have to always keep in mind. And the keynote is patient counseling is very important. Proper workup of the patient. As ACOG recommends, first line vaginal dilatation can be tried first. But any surgical procedure should be patient tailored and also surgeon tailored, depending on what the surgeon is more comfortable or what their expertise is. Thank you very much.
Thank you so much, Dr. Hira, for your enlightening talk and representing Dr. Ritu Arya. And I found this technique is very less invasive. And if it really, I myself personally, I don't have experience of this technique, but the video, it's really well explained and it looks like it's really less invasive. And but only thing what I am scared of little, because this is a blind technique, we have to dissect little blindly, although we are keeping the Foley's catheter, but still there is, I think there is a little higher chance of urethral injury and rectal injury. This is what I think. Like, I don't know how many cases have been done and what is the success rate, if you have any idea. If you could tell us.
Yeah, Usha, I'm here, Sonia here. So basically, yeah. I mean, Ritu has not been able to join because I mean, some procedure is going on for the mother. So she said that she's done some around 4 to 5 procedures, and out of which one was procedure which already had been done, a vaginoplasty which had failed and it has stenosed. So in that also she had used Intercede and it had worked up very well.
Great.
And the rest of the cases, and the maximum follow-up has been about 2 years, 2.5 years. And she said even these 2.5 years, when all her cases have been well epithelialized, graft well taken up. And the most important was the gratifying experience was the case which was redone again.
Great, great. It's really I mean, by looking the video, it's really sounding great to me, and really it can omit the need to do laparoscopy and to do the procedure like which is like all that Vishati procedure, olive,
I
putting
think we heard the advantages
olive
from
in
Dr.
the
Habib
vaginal
about the
dimple that I have
laparoscopic
seen. So
surgery.
I think this is better than that technique, and if done successfully, this is really a great job done for the
Dr.
patient.
Usha, can I intervene?
Yeah, please.
So I have been doing this for years, and the dissection doesn't take more than 5 to 10 minutes if you are in the right
Great.
place.
Okay.
And the trick is, and I never put a catheter in the bladder or in the rectum. The trick is just cut the raphe and put your fingers and just don't go enteroposteriorly. No, you go sideways. And the space is there. You don't have to do sharp dissection also. And you can use this mold with the interseed. Or initially we were using skin, but it gives a scar. So touch wood, not a single injury.
No, right. As you said very rightly, the very important thing to do, like the patients, I am doing laparoscopic creation of neovagina. So I do it with peritoneal pull through method. So the patient, they are not having a vaginal dimple at all with the flat vaginal dimple. So we also have to do little bit of the dissection from down, and the most important thing and the take home message is to do blunt dissection, as rightly Dr. Indu has said, because if you do a sharp dissection with the scissor or knife, it's going to bleed and it's create hell over there. So do blunt dissection and be in the right plane. And that, I think these are the key points to do the successful surgery like this.
The only problem we face is lubrication is not so good as with laparoscopic procedure. That's what I feel, At times, and if the skin graft is not very good, then also we have a lot of granulation tissue. So that problem is there. Yeah.
What I've also realized that with the modified David-Earls technique that we do laparoscopically, the vagina is created as though it is the normal rugosity of the vagina. You can't make out whether there is any surgery done there. Absolute normal rugosities are regained. So it's beautifully taken up, and definitely dilators are still required, but as compared to the other techniques which we've been doing right from PG days till date, I find this very, very acceptable.
Actually, you have to create the space, whether you do it Davidoff or you do put a graft. The space has to be created the same way, because space you will have to create from below only, I suppose. And one tip I found very good is that if you see from below, you will find two dimples always. And what I do is I put successive dilators. So I have two spaces and the median raphe is seen very clearly. So there's no risk of any injuries. And you try it, it's very easy. You get two canals and you just cut the raphe and then dilate it horizontally.
Very true. Dr. Goel, Dr. Uma Goel used to do it the same way, ma'am. So I've learned it from her. Dr. Uma Goel used to do it the same way with dilators. And she used to be very fast at it. Matlab, ek ke baad ek dilation.
Yeah, it takes 2-3 minutes and you have the space.
That's wonderful.
So,
thank you, ma'am.
Dr. Usha, would you introduce our next star speaker?
Yeah. Thank you so much, AOGD team and IAG team, to invite me to chair the session of Dr. Hafiz Rahman, who is the legend and he doesn't need any introduction. He is the teacher of teachers, and my first few lessons in the ABCD of laparoscopy I learned from Dr. Hafiz Rahman. And I also started, I started doing my total laparoscopy hysterectomy after that Hodel course. And it was really, till now, all of us, we have been learning from Dr. Hafiz Rahman. We have been watching his videos, and then we are doing the technique in the same way. So, Dr. Rahman, stage is yours.
Totally agree with you, Dr. Usha. I also started the LHS after that. We were together there.
Great. So, sir is here?
Yeah, he was here.
Yes.
Can I share the screen?
Yes, sir.
Yeah,
Yes.
1 minute. Can you see the screen now?
Yes, yes. we
Yes.
can
Yeah.
see.
First of all, thank you so much for giving me this opportunity to be with you today and giving me this topic also. See, this is a very, very important topic, and we have a large number of things to say about vaginoplasty, but understand that it's extremely important to understand the actual concept of what we are doing. Because this is what I usually find lacking in many of the works which have been done regarding the vaginoplasty. And it's extremely important to understand this basic concept. So looking at the embryology, as you can see here, you have the Mullerian ducts coming in and then fusing on with the sinovaginal bulbs which are coming from down. So here, see, one thing which is very important to understand, that it is not just two tubes coming and fusing. No. It's important to understand that it is two non-cannulated structures coming and fusing in the middle. If you can see here, two non-cannulated structures coming and fusing in the middle. And this is another non-cannulated structure. Now, this is the vaginal plate. If you see here, this one forms the vaginal plate. Now, this plate will form a cavity in between. So then it dilates. Can you see that? This plate has gone to two sides and a cavity is created. And here in the uterus also, it is a cavity is created. And in the formation of the cavity, there can be a lot of abnormalities. If you see here also, initial Mullerian, initial embryology, if you see, the sinovaginal bulbs are not actually like a lumen. They don't have a lumen. The lumen is created later. So what I wanted to understand, you to understand, is that initially there is a plate where there is no cavity. Now this plate comes in and attached to another plate. Again, there is no cavity. This is the first plate which comes and attached. And then there is another plate which comes and attached here where there is no cavity. And later on, this cavity is formed. Why this is important is because when there is no cavity which is formed there, there is something called vaginal plate. This structure is almost always ignored, and you will not be able to really understand the structure in the usual dissection. I'll show you the vaginal plate. I'll show you the vaginal plate but dissected out. Now, until and unless this structure is resected out, what will happen is whatever vagina you create will go into a sort of contraction because of this presence of vaginal plate. So this is one concept which I wanted you to understand. And the second thing is the levator. Look at the pelvic floor. The pelvic floor opens up where the vagina comes. It opens up and the vagina will come through the center part of the pelvic floor where there is a fibrous area, and it opens up and the vagina comes down. Now think of a patient where there is absence of vagina. The pelvic floor will be fused in the middle. Only the rectum comes down, the urethra comes down, and in the central part, the pelvic floor is fused and the levator comes to the middle. Now, whenever you create that space, the levator pushing out the levator, it moves back. The moment you leave it, it comes back to the center. This is one reason why many of the workers found that the re-stenosis of the vagina after creating the vagina is very high. So it's very, very important to cut the medial fibers of the levator when you create a vagina or when you do a vaginoplasty. This is the second concept. The third concept is that the rectovesical space, apart from the vaginal plate, you have something called a rectovesical space, which is very, very important. Because if you see the normal anatomy, every viscera is covered by a fascia. Like the rectum is covered by a fascia, the bladder is covered by the fascia, the vagina is covered by fascia, and in between these two fascias, there is a avascular plane. This avascular plane is extremely important when you dissect and do any surgery in the pelvis or like that, rather anywhere, because this is the area where you can actually travel. Like you are in a city and you have to travel through the center of the road. If you start traveling through the side lanes, what will happen? You will keep hitting on the walls. If your car goes into a side area where there is a walkway, you will keep hitting on the walls, which is the muscles, and keep damaging the muscles. Later on, if you do not dissect in this correct plane, later on this muscle will produce fibrosis and more of fibroblast invasion, which will constrict the vagina drastically. You may try to prevent all these things by keeping a mold, but that is not the right method. So it's very important to dissect in the correct plane where there will be absent or very less fibroblastic invasion, and there will not be any fibrosis. We do not want fibrosis to occur when you dissect that plane. The third concept is the functionality of the vagina, which is very, very important. But or a mucosa, vagina is a. Can you hear me properly?
Yes, sir, we can. We had a little bit of
a functional organ. It has a muscular lumen. It has a muscular lumen plus it has a mucosa which secretes. So it is a functional organ, because when you create the vagina, understand that in absent vagina, you don't have the Bartholin's developed properly, or you don't have the glands developed properly. So you need a secretion, you need a muscular lumen to really create the vagina, which is again very, very important for the functionality. It's not just an anatomical tube which comes from cervix to the perineum. So these are the concepts which you have to really, really understand when you perform a vaginoplasty. Until and unless you understand these concepts very clearly, you will not be able to do a very clear job. The problem of dissecting from below is that you will not be able to get into this correct plane, which I am telling about. I'll show you the videos of this correct plane, then you will understand exactly what I'm talking about. Now you have two types of vaginal reconstruction. That is a complete reconstruction of the vagina. One is patients with the uterus, and the other one is patients without the uterus. The difference is, in patients without the uterus, you can still have a peritoneal vaginoplasty. You can have the peritoneum which is used. I do not prefer much the peritoneal vaginoplasty, but in patients with the uterus, patients who have the uterus, most of the cases you will find the cervix also has become fibrotic, and it is not fibrotic, it is not cannulated. Only the uterus will be cannulated, the inside of the uterus endometrium, and it will be mostly a hematometra which is there. So in those cases, you cannot do the peritoneal vaginoplasty. Don't ever try to pull the uterus down to the small vagina. It will be a disaster. We have tried it and we have failed, and I know it will be a disaster. Do a proper ileal vaginoplasty where you can take the part of ileum and make it a proper conduit covering the cervix and then coming down up to the perineum. This will be the most ideal method. Now coming to the peritoneal vaginoplasty, as you can see here.
Right, sir. We are on.
As you can see here, this is not really Davido's method. This is basically the sunrise method. We have created our own method, which is similar to the Davido's method, where what we are doing is we are making the pouch of Douglas into the vagina. For making the pouch of Douglas, you need to take the peritoneal flaps from both the sides and bring it to the center. As you can see here, you can see the ureter. Now, bringing this peritoneal flap, one of the most important thing is to keep the entire fat and vascularity with this peritoneal flap. That's why you have to see, you have to dissect till the ureter. The entire vascularity and flap has to be kept intact. Otherwise, you will find that if you are taking a thin peritoneum, you will definitely find that this peritoneum will just crumble out. So you have to take the fat. You can see the entire fat is kept, and you can see that we are just dissecting the ureter out. A thick part of the fat is kept, and you can see that we are getting into the pararectal space also. deflecting the rectum. You can see the internal iliac veins over there. And now what we will do is we will do the same thing on the other side also. You can see a nice flap is taken. So until and unless you take such a vascular and vascular flap with the entire fat coming in, you will not be able to do it properly, or the peritoneum is going to just crumple. So you can see the thickness of the peritoneal graft which I'm taking. Now what I'll do is I'll go in the vaginal plane, in the vaginal plate area, where you can see that, if you dissect it from here, you can see we are just going little more closer to the rectum rather than closer to the vagina, closer to the upper part. And because we wanted this peritoneum to come in, and then we will enter into the correct plane. You can see it's a completely avascular plane, which you can see very clearly. If you do this dissection vaginally, you will find a lot of blood coming in. Here, you will not find any blood. And you can see that this is the vaginal plate. You can either excise the vaginal plate if you have the uterus, or you can cut the vaginal plate. This is where I have cut from below a little. And you can see that you can cut the vaginal plate to open it completely, or even excise it, and cut the lateral, cut the medial parts of the levatrinae, which is actually very, very important. So make a proper hole there. Can you see that? This is a very thick plate, which you will not understand when you dissect it from below. You can clearly delineate this plate and cut it. As you can see here, you can see the gauze piece there, and you can see that we are going ahead and cutting the medial fibers of the levatrinae, making a wide area where you can really put in the speculum. And once you put in the speculum, see, it's a pretty wide area, and you can even cut below also, like an episiotomy, to increase the width. Then you can take the peritoneum like a pull through and fix it on to the vulva here. And once you fix it on to the vulva, this is how you can see. You can see that it's opened right into the air there from below. And now you can close the upper part. This is how we close the upper part of peritoneum, so that the vagina is basically the pouch Douglas. So posteriorly you have the rectum, anteriorly you have part of the vaginal plate or the bladder if you have excised the vaginal plate, and laterally you have the peritoneal flaps which you have taken. And you can take whichever length you want. You can decide on the length you want depending on the ethnic population. Like in an African population, we actually take a little larger length of vagina. And in those populations, most of it we have done ileal vaginoplasty, because you can get a very good length with ileal vaginoplasty. And you can see that after you get adequate length of the vagina, you can close it onto the rectum here. You can take bites on the rectum and close it onto the upper part, and that makes the vagina. So between this between this flaps and the rectum, you will have the vagina. There is no problem in doing the serosa with the serosa of the rectum and closing it here. Close it properly, unless otherwise you will keep on getting a peritoneal fistula sometimes, which is very, very important. So as you can see here, we close it on the top, and the below part will become the vagina. So that is where we really make the vagina here. And then close it here. Now we will go to the video of ileal vaginoplasty, where here you can see you have a uniconvate uterus here. See, this is a uniconvate uterus, which you can see here. And of course, these cases will have severe endometriosis because there is no vagina. And you have a functioning uterus, which is there. And as you can see here, you can see the cervix is there, but it is not cannulated as such. And what you can do is you can dissect anteriorly and posteriorly. Why we dissect? As you can see the planes very nicely. Why we dissect anteriorly and posteriorly is because we want to excise the vaginal septum. So we dissect the bladder away anteriorly, we dissect the rectum down posteriorly. In between, you will find a nice fibrous septum, which is the vaginal septum, as you can see here. See, when I am dissecting, this is not the rectum, this is the vaginal septum here, which actually needs excision. See, now I am dissecting it posteriorly. When I dissect it posteriorly, can you see the plane? You can see the two layers of denovulus fascia, which is opening up, and you dissect exactly in that plane, a completely avascular plane. It is not like when you dissect it vaginally. I don't think I've done a lot of cases. We have completed more than 70 vaginoplasties now. I have never got such a good plane whenever I have dissected it vaginally, and I'm not able to understand the vaginal plate when I dissect it vaginally. But laparoscopically, you can see the clarity of dissection, and you will be able to nicely see the levator as such when you dissect it laparoscopically. And most of these cases, you will find the urethra quite dilated. That is something which you have to understand. You will find the urethra quite dilated, so you have to make the cut below the urethra near to the perineum, and you are making a cut like this on the mucosa, and just dissect it a little from here, and rest of it is done laparoscopically. That is, the area below the levator is dissected vaginally. The area above the levator has to be dissected laparoscopically. That is the theory of it. Now what we do is, you can see here, this area, see the difference. There is a lot of blood when you dissect it here. Even if I use a harmonic also, you will find a lot of blood when I dissect it from here. Now see, this is where we are cutting the levator fibers. As you can see, there will be thick fibers, and you will cut it laterally also. You'll cut it nicely. You can see the levator muscle which has come close in the middle. Cut it nicely to open it. As much as possible, you can open it, and then it will be much better. Now the second thing is, we need to reconstruct the cervix. As you can see here, what we will do is, we will just put methylene blue. Methylene blue is put with a Veress needle or a needle into the uterine cavity, then opened. You can see that the uterine cavity has the mucosa, but the cervix doesn't have the mucosa. So two methods or three methods. One is, you can amputate the cervix and put an encerclage at the isthmus and then come out. Second thing is, you can bisect the cervix and make a cervical canal. The cervical canal can be made in two ways. One is by keeping a Foley's catheter, and the other one is keeping the appendix. You can take the normal appendix of the patient, you can thread it onto the Foley's catheter, and the appendix comes exactly at the level of the cervix, which will act like a mantle. You can see the uterine cavity here. This is a nice cavity which you can see here. From here, it is actually non-cannulated. So this is the area which you have to now produce like a tunnel kind of thing you have to do. Now for that, what I've done is, I put the Foley's from below. Now I'm closing the cervix. I'm wrapping the cervix, the cut cervix, onto the Foley's, and I'll put a stitch onto the Foley's also, so that the Foley's is going to stay there for almost 45 days, and then it will fall on its own. When the vicryl gets disintegrated, it will fall on its own, because you cannot go into the ileum and see the Foley's catheter. And this is the way we fix the Foley's. I've fixed it with the bougie. I'll later on take out the bougie. Now I'm taking the bite onto the Foley's, as you can see here. Sister? As you can see here, I'm taking the bite onto the Foley's and then wrapping the wrapping the cervix onto this Foley's as such. See, that's how you bring the cervix on top of the Foley's, which will allow us to form a tunnel of the cervix. Now, after doing that, I'll start taking the ileal graft. So this is how we take the ileal graft. You have to see the vascularity of the mesentery, and you take it almost 14 centimeters from the ileocecal junction. Do not take it very close to the ileocecal junction because you will not be able to bring it down. And below that, you can see a pelvic kidney, which is the bulge there. This is a patient with a pelvic kidney, which is a usual thing in many of the Mullerian anomalies. Even actually tomorrow also we have a patient like that. So this is the ileal graft which we take. You can see the vascularity also. So this graft with the vessel, can you see that? This is the vessel vascular part. This is the vessel graft which is there. And this graft, you can take the ileum down, and one end of the ileum is fixed on to the perineum. The other end of the ileum will come upwards and it will engulf the cervix. Can you see the ileum there? That is the ileum which is brought upwards. The one end is already fixed on to the perineum, and you can bring this ileum up and you can allow it to engulf onto the cervix completely. See that? Forming the fornix. You can take it up nicely onto the uterus so that the cervix get engulfed completely, and that will form a clear fornix. So this method actually will create a good flow of the menstrual blood. For almost 2 years, these patients definitely have some kind of a menorrhagia, basically because they must have had this, if you're not doing the surgery at a young age, they will have the hemosiderin reaction onto the endometrium, and the endometrium will be a bit abnormal, which will create a lot of menorrhagia. This is seen in almost all our cases of Robert's uterus or the Ovira syndromes, which we have operated. Almost 1 to 2 years, they will go for a menorrhagia. Then it slowly, the endometrium gets transformed and it gets controlled. So this is where you pull it, and this is where you take it posteriorly. You can bring the posterior part of the fish mouth ileum and suture it above the fornix. Like it creates a nice fornix, a nice fornix in the vagina. When you do a vaginoscopy, usually it will be very clear. As you can see here, you can pull the ileum upwards and create that fornix very nicely here. And this is the ileum. You can see down here the ileum with the vascular pedicle. You can see the vascular pedicle coming here. That's a vascular pedicle, and you can see the nice vagina which is formed with the uterus. If you do a laparoscopy in these cases, later on you will not even actually understand. It's clearly very nice formation of the vagina. The only issue which we have had is basically, see, that's a vascular part which is coming down. Then you can re-anastomose the ileum, as you see here. You can re-anastomose the ileum. You can put some releasing incisions in this area so that the stretch will be less on the vessel, as you can see. Now, one of the only problems which we find is that whenever the patient takes food, there will be some amount of intestinal juice coming from down. So what we have done is you can do a laser vaginal rejuvenation onto the ileum, which will reduce the secretion, or what you can, or within another maybe 1 to 1.5 years, the secretions will come down drastically, and it will work out very good. Now here you can see how I dissect the vaginal plate. See, you can see the anterior. This is the Mullerian anomaly where there is only a uterine nodule which is there. And you can see the anterior is dissected first, as you can see here. You can see the planes very clearly. As you can see, can you see that? This is a completely avascular plane which you can see. The fascia over the rectum should never be touched. You should keep the fascia over the rectum completely intact, as you can see here. Now we are just taking out the, this part of the uterus is a functioning uterus. I'm just taking out the non-functioning part of the uterus with the cervix, because this is how we excise the cervix. Actually, in some cases, we excise the cervix and connect the functioning uterus onto the ileum directly. And you can see that is the uterosacral ligament actually we are cutting. And you can see the vaginal plate which is coming in. There you can see the ureter, which is pushed laterally. Now can you see that? This is the vaginal plate. This part which you see is the complete vaginal plate which we are excising. You can see the bladder here, you can see the rectum here, and in between you can see the complete vaginal plate which is being excised. See, this fibrous tissue, which is actually the Mullerian duct, which is not cannulated, has to be excised completely if you really want to have a proper functioning vagina without any constriction. This is very, very important concept which all of us have to understand. And this can be excised completely up to the sinovaginal bulb, which is a very, very important thing. Okay, that's the ileum which we are connecting on to the, this is the ileum which you can see, which we are connecting on to the, anyway, I'll just skip that. Now, post-operative care, which is very, very important, you have to have adequate dilatation. First, we keep around 2 centimeters because the ileum is not very big. You can keep around 1.5, 2 centimeters diameter mold. We have our own mold, which is prepared with a small hole in the proximal part. You can stitch the mold onto the vagina. Never stitch it to the skin. You can stitch it onto the vagina, and that mold stays there for the first 10 days. First 10 days, we do not remove the mold at all. Now, because the vagina, the ileum has to heal and it has to get attached. Now, after 10 days, we remove the mold and do a dilatation under anesthesia. We keep a little more bigger mold. So every month, we change the size of the mold and it keeps dilating to the adequate size, whichever size you want. You can dilate the ileum to quite a large size. Actually, you can dilate the ileum and it will almost look like the normal vagina, as you can see here. See that? See how good is the vagina. You can see it's I can put in 2 fingers very nicely, and I can created a nice vagina. And the best part is the vaginal mucosa. The smoothness of the vaginal mucosa is actually, I would say, better than the original vaginal mucosa. But slowly the mucosa gets transformed into the vaginal mucosa over a period of time. Now, this is not really without complication, but most of the complications which you have seen are one is constipation. Constipation occurs if you have not gone in the correct plane. The correct plane dissection is very important. When you do not dissect in the correct plane, and when you have done a radical dissection there, you can injure some of the nerve fibers, especially when you are going and cutting the levator. You have to be a bit careful. You can you may cut some of the nerve fibers, which will lead to a constipation for the patient. And this constipation, if it occurs, we have seen that it stays for almost 6 months. So 6 months, we are giving laxative for this patient. Now, fistulas can occur because I have not seen fistulas in our cases, but I'll show you a fistula. This is a patient who has been where the mold was kept for almost 10 years. When she came to me, when the mold was removed, she was leaking urine. 10 years the mold was kept in the vagina after a vaginoplasty, and this is what happened. You can see I've gone into through the vagina and through the bladder. I've gone into the bladder through the fistula, as you can see here. See that? That is the cervix, which is there. That's a uterus. This is it's a nicely formed vagina. That's a cervix. Can you see that? That's a cervical canal. And when I come back, You can see the polyps there on the fistula. And when I'm coming back, you can see the fistula. This is the fistula there. And when I go into the fistula, you will reach. You can see the cervix on one side and you can see the fistula. And this is the beauty of vaginoscopy, which is again another very important topic which I really want to cover in vaginal septum. See, vaginal septums again is a part of vaginoplasty. One of the concepts which you have to understand very clearly in vaginal septum is that again, see here, there can be different types of vaginal septum. You can have a vertical fusion problem, you can have a transverse fusion problem, and you can have a combination of the vertical and transverse, like what you see in the Overa syndrome. Now, in these kind of transverse fusion problem, it's not that simple like what you see in this picture. Sometimes you find that the thickness of this septum can be very high, even up to 2 centimeter or 3 centimeter. I've seen the thickness. In such cases, what happens is it is not just enough that you just cut the septum and produce a canal. You have to resect this area of the vagina. Very, very important. You have to, if it is a thick septum, just cutting the septum does not work out. Basically, because you have to resect that area. You have to completely resect this much. If it is a 2 centimeter septum, you have to actually resect this part of the septum, because this is a fibrous. It is not that the vagina is there, the vaginal wall is here and there is a septum. No, this entire thing is non-cannulated. It will come like this. It will actually come like this, non-cannulated. So you have to resect this fibrotic area and do a pull through. You have to pull the upper part and fix it on to the lower part after resecting that fibrotic area of the septum, which is very, very important. Now, sorry, let me just... Yeah, you can see this video. See, one of the biggest problem in doing a septal resection, this is a patient who had menstruation. There is a small hole, that's why menstruation is there, but a blind vagina. You can see a completely blind vagina. This was actually presented in the AGL journal. Completely blind vagina, and there is absolutely no hematometra because there is a small hole, and she was menstruating. Okay, so the biggest problem of doing it vaginally is that you will not understand exactly where to put the incision. You may put the incision little anteriorly, you will go into the bladder. You may put the incision little posteriorly, you will go into the rectum, and you will not really understand how much of thickness of the septum is there. But here you can see that you are going in the correct plane. As I dissect in the vaginal septum, you're going in the correct plane. Then I will open from above onto the upper part of the cannulated vagina, because this is a septum. MRI has shown clearly a septum. So the upper part of the cannulated vagina I will open into. As you can see here, we are pushing a gauze piece from below onto the septum, and then I will open into the upper part of the vagina. Sorry, I think it, yeah, fine. So I'm opening into the upper part of the vagina, as you can see here. And once I open into the upper part of the vagina, I can see the septum very clearly. Since I have the bladder in my hand, I know I'm not going to cut the bladder. I have the bladder anteriorly in my hand, and the rectum is far down. See, this is the upper part, and I can cut the septum very nicely. This is a relatively thin septum, but we have excised that septum completely. We're not putting an incision. We went ahead and excised that part of the vagina or the septum completely, and then did a pull through, as you will see later on. And we went from below. You can see the upper part of the vagina and the lower part of the vagina. And then we had pulled the upper part of the vagina down. You can see that unlike the usual septums, thick septums, you can see that the vagina comes down very nicely because that part of the septum is excised completely. As you can see, and some amount of mobilization of the upper vagina is done laterally and anterior and posterior, so that the vagina comes down and you can see a nice complete vagina is formed, as you can see here. So this would be an ideal method to in most of these kind of cases. Now, it's another thing is it's very important to understand these kind of septums also. This is here you can see a vertical septum. We have started doing all these things by, do I have time? How much time do I have?
So we're all ears. You continue.
Okay. Now, you can see that this is the cervix on one side, as you can see here. We are going into the uterus. That is the cervical canal on one side. And there you can see that we are gone into the uterine cavity. A lot of mucosa is there. That's the uterine cavity. You can see the uterine cavity there. And coming back, you can see the septum. That's a vaginal septum, and you can see the other cervix on the other side. Here you can see that two cervixes are completely separate. When the matter of the cervix divides, it is known as a dicholis. When the cervix has, the matter of the cervix doesn't divide, and in the middle there is a division where the only the mucosal part is divided. It is known as a septate cervix. Here you can see that there is completely separate cervix, as you can see here. And you can see the laparoscopy picture. You can see it's a completely separate uteruses. That's a uterus didelphys. So it's a completely separate uterus, separate cervix with a vaginal septum. So we went in through vaginoscopy. See, this is very important. Nowadays, we have stopped doing the usual vaginal cutting of the septum because we can go in any plane. See here I can see the cervix very nicely, and I can come exactly on this area. I can see the other end of the cervix also. That's the other cervix. And I can start cutting exactly. And the advantage of vaginoscopy is that the fluid will push the anterior and posterior. Anterior bladder will be pushed up. The posterior rectum will be pushed down. So it's very easy to cut in the middle in these cases. As you can see here, you can cut in the middle in this patient. See, it's very easy now to cut the septum, and it will be in the exact plane. This is very, very important. You cannot go a bit anteriorly or you cannot go a bit posteriorly. You have to cut in the exact plane in these cases, and you can cut the septum completely. But you can see that these cases, the cervix is wide apart. So you cannot unify the cervix here because it's a didelphys dicholis. But at the same time, you can see in this patient, here again, you can see the cervix, which is not that wide apart, and you can see the septum here. And when we go in and cut the septum, as you can see here, when we go in and cut the septum and reach near to the cervix, see, when you reach near to the cervix, you can see that the matter of the cervix is not really divided. You can see the the clot is creating a little problem. You can see the two cervix are coming together, and it's really a septum in between, inside the cervix. See, now you are seeing that it's almost becoming like one cervix. And we have entered into the uterus. You can see that it's actually the uterine septum is only on one area, and in the middle there is no septum. See, that's a uterine septum which we are cutting in the same patient. So that goes with the uterine septum. And when coming down, you will see that the cervical septum is only in the cervix. In between, there is no septum. There is absent cannulation in that area. So different types of combination can occur in these kind of patients. See here, this is the cervical septum, which you are seeing. So I'm just cutting the cervical septum from above down also. That's a lateral metroplasty which we are doing. Just to open it up and coming down. Can you see the cervical septum? That's a cervical septum. So this is a very unique case. Actually, you can see the cervical septum there getting cut. See, that's the area where we finish cutting from below. Quite a thick cervical septum. So generally, I would prefer to cut the cervical septum and put an encerclage in these patients rather than keeping the cervical septum. So can you see now the cervical septum is getting completely cut?
So how come the cervix is appearing as wide as a vagina?
No, it's not appearing as wide as vagina. It's inside the cervix. It will be quite wide in these cases because it's not that it is not unified. It's not the septum inside. There will be some amount of distancing of the cervix also in these cases.
Hafiz, but you had said they were bicollis, right?
No, the previous one was bicollis. This one was septate cervix. I was just showing you the difference between the bicollis and the septate cervix. I showed you two videos.
Okay.
Now, this was a patient actually who had 5 laparotomies. She had 5 laparotomies before, and each time they have drained some fluid in the pelvis. And usually the fluid will recur again in 2-3 periods, and she had a pelvic kidney also. So she had actually traveled a long way from the other part of the world. And you can see the mess inside when we went in because of the previous laparotomies. And she was just 24-year-old. So we started dissecting the bowel down, as you can see here.
What is the planned surgery, Hafiz?
No, she had a pelvic mass. We actually didn't know what it was. The problem with her is she is not married and she doesn't want us to rupture the hymen also.
Okay.
Now we are dissecting it, you saw the uterus now. So we had the addition of the bladder. So we just wanted to have a proper diagnosis because even MRI was not really showing a proper diagnosis. So we dissected it down here. And when we dissected the bladder completely down, we could see a massive hematometra. But she was menstruating. So that's a massive hematometra, as you can see here. So hematometra in a menstruating patient, see that? Hematometra in a menstruation patient, first thing which has to come into your mind is an Overa syndrome, where you have a uterus didelphys, or you have a uterus bicornate uterus, or even a septate uterus with the, can you see that? That's a hematometra. So yes, that's hematocolpus. So you will have a septum, you will have a vertical septum which comes on the middle and it becomes a transverse septum. So only one side is blocked actually.
So it was not picked up on the
from the other side. So, but one side will be blocked, and these are the patients which can have unilateral endometriosis. So she didn't want us to touch the hymen. So we went in vaginoscopy. This is actually one of the first ever vaginoscopies reported. So we went in, this was 15 years back. We went in vaginoscopically, and this is one of the first ever vaginoscopic surgeries, not vaginoscopy. So we went in vaginoscopy, and with the resectoscope, this is the one cervix which you can see where it was menstruating. Then we put in a resectoscope, and then we had cut onto the septum, as you can see that bulge on the septum which we have cut. And it was a Overa syndrome, and we could cut the complete septum, and she was completely relieved of, as you can see here. It's not very thin septum in many of these cases. You can see the thickness of the septum. and you can see the altered blood which is there inside.
So what is the trick to know that you're going into the right plane here?
See, now
Which
you
is the
can
point
see
of dissection?
the cervix in between. Total amount of altered blood which is coming. And you can clearly see the other cervix. I think it's you can clearly see the other cervix, and then you can direct yourself onto the other cervix, and it will be quite easy, as you have seen in the previous videos. Now, this is another case where we had actually young patient. When you did the vaginoscopy, there was a nice cervix, but this cervix was looking like a unicorn. And on laparoscopy, there were 2 uteruses. This patient got pregnant after this, and we had put the Veris needle in one uterus and started injecting methylene blue. But on vagina, we could see the methylene blue is coming from somewhere. We were not able to understand where the methylene blue is coming, and we could not see the septum. When you put in the speculum, this is what you see. There is only one cervix. So we went in backwards, and you could see the methylene blue coming from the side. Can you see that? So this is the septum. So septums need not be always in the center. Septum can be, there can be differential development of the cannulation of the vaginal plate on the 2 Mullerian ducts can cannulate into different sizes. And the septum can be towards the side also. And when this kind of a septum occurs, there is usually cryptomenorrhea. So in cryptomenorrhea, one of the features you will find is a unilateral endometriosis. And there can be infiltrating endometriosis, which can infiltrate into different organs also. In this case, when we went in, we saw 3 holes. One hole, as you can see, it went into a blind pouch, which was actually an endometriotic pouch, which we had resected. We had resected this pouch. And on top, you can see a vesicovaginal fistula. That's a vesicovaginal fistula on top. And on the right, there was a normal cervix. Can you see that? There were 3 holes. This is one hole, this is another hole, and this is the normal cervix on the right side. So I'm going through the normal cervix. See that? That's a normal cervix. We entered into the uterine cavity where we have put the Veris needle. So what we did is we resected this septum completely. We excised that endometriotic cavity which is there. We left the vesicovaginal fistula to close on its own, because once the cryptomenorrhea is corrected, the endometriosis doesn't grow, and then you find that it closes on its own. See, that is the cervix on the right. This is the blind cavity, and on top is the vesicovaginal fistula. That's a vesicovaginal fistula. See that? So these are endometriotic fistulas. The infiltrating endometriosis can produce fistulas like this, which are very important to understand. And this is the biggest advantage of vaginoscopy. You can walk in through that. You put in the speculum, you will never understand what this is. You can really walk in through the vagina. Can you see the septum now? And that is the other part of the vagina. You can see the septum here. And that is the other part of the vagina, which you can see with the normal cervix. This is the picture you will get if you put in a speculum. It will be very difficult to understand this septum if you do not do a vaginoscopy. Yeah. So thank you so much for your patient listening.
Thank you so much, Dr.
Much love to have you continue with these lectures. I mean, it's really interesting to see these videos, and we're enthralled. And actually, Dr. Ragini, who's the next speaker, she has to leave for another webinar. So, sir, if you would be kind enough to stay, and we would like to see more of such interesting videos if possible. We can have them after Dr. Ragini's talk. And we can have Dr. Usha the discussion also.
Yeah, Doctor, I have.
Vaginoplasty is one topic which you can have a full day webinar.
Yeah.
I think that we can have it again. You know, Hafiz, you should, we should plan another webinar with you for all these procedures, because you have a plethora of cases.
Topic.
One thing
we were discussing.
is that, see, did you understand the concept which we are trying to put in regarding the vaginal plate and the these are original concepts, and the plane of dissection and the levatrine, cutting the levatrine. This is very important in vaginoplasty, because once we started doing it like that, our rate of constriction of the vagina has reduced drastically.
And it seems, Rafiz, you're getting so many cases. You've already done 70 of them. And especially the ileal one, I was just wondering that you've talked about 3 complications. Sorry, I'm barging in because it still has to be, the experts are there who are going to be commenting. But my one little question, with due respect to the experts,
No, ma'am, please.
Is what are the other complications, and what do you tell them for future, like for pregnancy? And of course, functionally, it has become nice and, the roomy vagina. So what is your take on that? What do you suggest to these patients, and how long has been the follow-up for your cases?
See, we have been doing ileal vaginoplasty, I think, for the last 8 years now. So in these patients, they have become pregnant, and it is a very good result because the uterus is quite good. The only problem is, what we are worried is the cervix. See, many of the cases we have to actually amputate the cervix, because see, the cervix may be sometimes long, non-cannulated cervix there. We have tried appendix in some cases, or what we do is, if it is a long one and we feel that it cannot be cannulated, we amputate the cervix. In such cases, we'll have to go in and put an encerclage when they become pregnant. Otherwise, in patients with no uterus, the results are really fantastic. The results of ideal vaginoplasty, I would say, is better than any other method. The only problem is, ileum is a small structure. Ileum is not as big as vagina. You have to really dilate it to that size over a period of 6 months to 1 year. So what I usually say to the patient is that you do the procedure 1 year before your marriage, so that I get 1 year's time to make it completely into a normal vagina. You saw that video of the dilatation. It becomes almost like a normal vagina.
Yeah, absolutely. Very nice.
I just have 2 questions.
First time in one of the Sunrise conferences. Very good.
Sir, I just wanted to ask 2 questions. And in which cases? Yeah.
Dr. Usha, sorry for interrupting, but we would love to ask. I also have few more questions for him, but Dr. Ragini has to go for another webinar. So can we just hold on and we'll ask after
sure.
Dr. Ragini's talk?
Why not, Kanika? We'll continue with Dr. Hafiz. It's such a good evening, sir. It is really lovely to see you, and it's an honor on the dais with you. And everybody is saying that they are trained by you. I think I was your first North Indian student. So I think we will continue with Dr. Hafiz. It's lovely to see his video. As a living legend, I can come again, Dr. Kanika, no problem at all. I'll join again you in next one. Continue with Dr. Hafiz.
We can continue with Dr. Ragini's lecture and then come back to Dr. Hafiz.
I don't know Dr. Hafiz has that much time, and the thing is that I think after these video, nobody wants to listen anything. I myself is mesmerized. It's not a big deal at all, Dr. Kanika. I will come again. You will continue with Dr. Hafiz.
ma'am.
So I'm so sorry. The problem is I have to leave now. We'll definitely come back with another webinar, because webinars are easy to conduct. Just like
the third time when I am listening your this congenital abnormality, and every time it is so wonderful, Dr. Hafiz. It's really, you are a living legend.
So we'll have to have vaginoplasty part 2. Ankita,
yes.
Be prepared.
Yes. And only Dr. Hafiz, so we can have all the answers.
So, what do the experts say, ma'am? Dr. Malvika, Dr. Achla, what do you say? I mean,
we should listen to Dr. Ragini now, because Hafiz has to come again.
Yeah. We will have to listen to Hafiz for a very, very long time. So we call him for vaginoplasty.
Dr. Hafiz will trouble you again, and you have to come to us again.
We will have a webinar on Mullerian anomalies.
Yeah.
Okay, done.
For
Done.
sure.
Sure. Thank you,
And
sir.
please
So-
send me link also, Dr. Kanika, for that malarial abnormality.
Sure, ma'am. Sure. Why not?
Thank you so
Definitely.
much for your patient listening to all these things. So
Sir,
thank
would
you.
you be there for some time to answer the questions?
डॉक्टर हफीज थोड़ी देर तो रुकिए ना।
Yeah,
बढ़िया
you
तो
can
नहीं
ask
बोलूंगी
whatever
जितना आप
question.
कहते हो, लेकिन जो भी है थोड़ी देर तो सुनिए।
Any questions?
Sir, I had one question, if with the kind permission of Kanika.
Sure. Okay.
Yeah, sir, do you have any experience of creating neovagina with XY female? One patient has been approaching me. She's just 16 years old, and and she is 16 years old. And then she is a complete androgen insensitivity syndrome with testicles in the inguina. This patient is not having any uterus, and the testes are there in the inguinal canal. So how we can proceed with this patient?
We had a case actually last month. We had an Arab lady who came in. They had a family. We have 5 people in the family with testicular feminization syndrome. So we need to remove that testis, and then it will be the same. This will be absolutely same, and it's actually much more easy in testicular feminization syndrome to create the vagina, because you will have a longer pelvis. These patients are quite tall, compared to the normal female patients. So you will have a much longer pelvis, and you have the creation of vagina is much more easier, even though we call it as an android pelvis.
She has.
What about the creation of the labia?
Huh?
What about the creation of the labia?
It will be like normal. There won't be any.
She has got labia,
exactly
but
like a Mullerian-Rokitansky syndrome.
But she is having labia is there, but the problem is she is having micropenis and the inguinal testes. So should we wait for her to grow up at the age of
nothing will grow. Testicular feminization syndrome, basically it's a receptor defect. So nothing will grow. So I don't think even if you give testosterone, there is a use, and the testosterone levels will be normal. So what you have to do is you have to remove the testis, because there is a high chance of testis getting into malignancy, and you can excise the micropenis. We do a lot of transgender surgeries in our hospital here. Means we like conversion of male to female and those kind of things. In those cases,
the next webinar, transgender also included.
In that, Dr. Usha, when there's a micropenis, basically it has to be reduced from the shaft. And because you cannot remove the glans, it is the most sensitive area, and it has to be fixed behind. It is like something like the enlarged clitoris in the female, and we have to do that surgery.
Okay. So
true.
Tonatectomy, we have to wait till 18 years, or we can do it at the age of 16?
You can do it much earlier. You don't have to wait for these patients.
Okay. Thank you so much, sir.
Because the maximum time in ileal vaginoplasties, maximum time you get for the mold, the better the vagina becomes. Because it will take usually 2 years for that discharge to reduce. Doesn't reduce in 1 or 2 months. No, she will keep on getting the discharge, and it's a big nuisance. Actually, they may have to keep on putting the pad whenever they start eating.
Not only we have to remove those testes very early, you never know when it become the malignant.
True.
Thank you so much, sir.
Thank you, respected speakers and experts, for a thorough academic feast. All our delegates enjoyed the deliberations, and I'm sure everyone truly benefited. As we proceed to the next session, I take the privilege of inviting our renowned experts and discussants for the session. Dr. Geeta Mediratta, ma'am is Senior Consultant, Institute of Obs and Gynae, Sir Gangaram Hospital. She's Chairperson, Urogynae Committee of AOGD. She has been Chief Editor of AOGD. She's a devoted teacher and extremely popular among her students. Welcome, ma'am. Dr. Sonia Nayak, ma'am is Director and Unit Head, Max Super Specialty Hospital, Saket. Her fields of interest are advanced operative hysteroscopy, laparoscopy, managing high-risk pregnancy and endometriosis. Welcome, ma'am. Dr. Swati Agarwal, Ma'am is Professor, Nodal Officer, JSSK and Lakshya, Department of Obs and Gynae, Lady Harding Medical College, and she's awarded Foxy Late Dr. Praveen Mehta Training and Dr. Kamini Rao Orator Award. Welcome, ma'am. I request Dr. Geeta to please introduce Dr. Ragini Agarwal.
Thank you, Ankita, and thank you, Kanika. And I've been following it in between from my OPD, and it's a wonderful session going on. And now it's my real great honor and pleasure to introduce Dr. Ragini Agarwal, who's a very close friend as well as a very, very astute clinician. And we all know her, and she's a fellow clinical gynae endoscopy from UK, has master course cosmetic gynecology and laser from Europe and American Academy. And she's currently clinical director of Obs Gynae and Minimal Access Surgery and head of the Department of Cosmetic Gynecology and Pelvic Reconstructive Surgery at Pratiksha Hospital in Gurgaon. And of course, she has got innumerable credits to her, on her honor. And I won't stand between you, Dr. Ragini, and the audience. And may I now have the honor of inviting you to address us, please.
Thank you so much, Dr. Menti Datta. And it is really great honor to me today on the dais with my teacher, Dr. Hafiz Rahman. And thank you, Dr. Kanika, for giving me this opportunity. And I'm thinking what I'm going to speak after Dr. Rahman's wonderful videos. Just made. My slides are in full or not?
They were visible, ma'am. Now I can't see them.
Yeah. So I will start with a vulvovaginal rejuvenation, the topic given to me, and it is a hot discussion today. The question is that what is new about it? The rejuvenation word means rejuvenate the thing. Here we are talking about the rejuvenation of the vulva and vagina. How much surgery is going to do a wonder for any rejuvenation? I think when we put a word surgery, surgical rejuvenation, it is not basically a rejuvenation, it is a correction or reconstruction. When we go for the word rejuvenation, it is basically again a thing which is changed, dried or atrophied to regenerate to some extent to become the normal. So it is a broad term for vulvovaginal corrective treatments. These procedures are meant to correct problems that can occur giving birth or during aging. Maybe because due to the cosmetic reason or to solve age-related problems such as lack of vaginal tightness and urinary incontinence and the changes of the GSM. Basically, if you ask me why this vulvovaginal rejuvenation has become popular, it is the addressing the lack of vaginal tightness, mild urinary incontinence, and the changes of the GSM. And today the menopausal, perimenopausal women are there in a large number, and they want to have an active life, not only physically, mentally, and also sexually. So we have two types of main groups of women with us. One is a postmenopausal woman, and second, our audience is a postpartum woman. And we all know today the age of the delivery is also increasing. Our pregnant patient is in the age of 32, 35, 38. So basically, when they come after second delivery, they are almost perimenopausal. So what is our area of scope? Maybe the younger patient after postpartum rehabilitation, or our menopausal patient who are suffering with the GSM or vaginal laxity, mild SUI. It may be surgical or non-surgical, but my focus when I talk about the rejuvenation is a non-surgical one. It includes cosmetic procedure to enhance the aesthetic appearance of the vulvovaginal region, as well as functional vaginal repairs to enhance or help restore sexual function following the changes after childbirth or aging, or address problems like vaginal dryness, which is a very, very big thing for an elderly woman, or mild SUI or GSM related incontinence. Because we all know that when we talk about the GSM related incontinence, it is basically not the SUI, it is a combination of SUI and the urge incontinence because of the uroepithelium is getting atrophied in the menopausal woman because of the lack of the estrogen. The thing is that the biggest discussion is between the regulatory bodies, between the academic bodies, and between the doctors who are providing the cosmetic functional services, that what is really it should be done, not to be done, it is in the medical realm or not. But the thing is that the client, the female patient of all ages, they are enjoying this problem, these all procedures. It boosts their self-confidence, improve their well-being and vitality, eventually affect the quality of their lives. So just to recapitulate, the appearance of genitalia can be affected by the traumatic childbirth, previous surgery, frequent body weight changes, intensive physical exercises, and the age. So what we are going to discuss is a vaginal laxity, GSM, SUI, and in the end, the third part, which is the most important part and totally neglected in the non-touch part, is the vulval rejuvenation. If I go with the surgical and the non-surgical both, I can have a full conference on that. So here, the main thing, considering rejuvenation, I focused on the non-surgical. So when we talk about the vaginal laxity, it's the high time when we really talk about it, not think that it is something frivolous or it is only the partner wants it. It is a woman herself, today's empowered, intelligent woman, doesn't want to become an older granny. They also enjoy the sex, and they themselves, they want this vaginal laxity to be corrected. So this is a new term coined by the cosmetic expert, the vaginal relaxation syndrome, to address loose vagina and the gaped genital hiatus, and it is a topic of a great discussion. We all know there's a widening of the vagina because of the stretching of the tissue, and this laxity create a gaping perineum, reduce friction sensation, and diminishing sexual satisfaction. And in turn, it can lead to a female sexual dysfunctions, pelvic floor dysfunction. What I mean to the pelvic floor dysfunction, this vaginal laxity, which we are seeing today with a gaped vagina, can ultimately lead to a POP also, or a patient can have a mild anal incontinence or a urinary incontinence. For that, she has nobody to discuss or go for a treatment. I still remember my PG's days when the women come in the OPD and say, "Madam, मेरे को air आगे से भी निकल जाती है," and we have no answer to give them. And usually nobody listen it, nobody give any answer to them. And believe it, it affects their quality of life and causes lots of problem in their family and the marital life. So VRS is a one end of the spectrum which leads to the pelvic organ prolapse, to the complete prolapse. And it is a poorly understood symptom of the pelvic floor dysfunction. Vaginal wall, much like the rest of the skin, are made of the lots of the fibrous material and the collagen that give its flexibility and the strength. The word collagen is a point of the discussion when we talk about the rejuvenation. And when a woman goes to the vaginal delivery, here sensitivity and the tightness both are decreased, and it leads to the vaginal laxity. Here, although Dr. Hafiz has given a wonderful detail of the vagina, so when we thinking for the vaginal rejuvenation or the vulval rejuvenation, reconsidering or refreshing our whole anatomy, physiology is very, very necessary. And we should remember the younger women have a collagen which is type 1 or a type 2. And with the age, it leads to the type 4 and the type 5, which are a small collagen fiber, easily breakable, and they have no strength. That why gradually the vagina become more loose as the woman is, and there's no friction, and even sometime it causes at the later age when patient has a intercourse because of the thin epithelium, dried lubrication can have an injury also. So childbirth is the only not the cause. The advanced age, menopause, they also causes this problem. And there's a weakening and the relaxation of the vaginal muscle, loss of the voluntary pelvic floor muscle, decreased vaginal sensation, and the loss of urinary control. And it all lead for the sexual dysfunction. Think of a woman having an intercourse and there's a leaking of the urine at that time. It will be all the time it going to the traumatize the both of the couples, and it will lead is not even willing to have a sexual encounter. So it can lead to a negative impact on the female sexual function, body image, and the quality of life. So this is very important for the self-esteem. Pelvic floor dysfunction is direct relation with the looseness and the unsatisfied sex. So what we have to do? Pelvic physiotherapy, it is a very, very important tool, and it should be introduced right after patient has a delivery. What we call is a postpartum rehabilitation. Not only this, women at the antepartum period, we should think about it. We should send the patient for the exercise, core muscle development, because all the pelvic muscles, they are really inserted towards the core muscle only. So this is a most important thing. Then there's a non-surgical vaginal tightening, and maybe there's a combo of the surgical vaginoplasty and the perineoplasty along with the non-surgical vaginal tightening, depending upon the case. So we have to individualize every case. It is not something like a gimmick. It is a medical problem. We have to take a detailed history. We have to take a detailed examination, and every woman has to given the customized treatment what she really needs. So literally I'm just touching with the surgical regeneration. When the patient comes for the surgical regeneration, which is basically is a surgical correction on the reconstruction, it is not a regeneration. The vaginoplasty is an old days procedure. We are all doing it like a colpoperineography. It has given the name of the aesthetic vaginoplasty and the perineoplasty for the vaginal tightening. Although the procedure differ little bit from the perineocolporaphy, then we have a labia minoroplasty, clitoral hood reduction for an excessively large clitoral hood, labia majoroplasty for enlarged or the lax labia majora, and sometimes the labia majora augmentation for the hypertrophic labia majora. The hypertrophic labia majora. The question arises, it is really hypertrophic labia majora? No. Many a time what happens with the aging, there's a loss of the adipose tissue, and those labia majora become like a shriveled nest, and they are really falling outside, and they are not able to cover the vaginal introitus. They are not able to cover the labia minora, and labia minora seems to be prominent. So this examination is very necessary. If you go for a labioplasty, these women, you are not going to help them. Those women need a labia minora augmentation. I will come again what to do for the augmentation. So this gynecoplasty surgery has been performed since ages, found in the Sushruta Samhita also, but still people are not accepting. It is present in the female physician tortilla diudica long back and the ancient inception. We all know it is a blanket term to restructuring the vagina surgically, and perineoplasty is the reconstruction of the damaged perineum, which usually occur during childbirth. If you do a vaginoplasty alone without a perineoplasty, if there's a deficient perineum, it is not going to help the patient at all, because you have to give a aesthetically muscular support to the vaginal tightening. And these two together called the surgical vaginal rejuvenation. Anatomical consideration is really necessary to understand what is the vaginal anatomy, what is the pelvic floor muscles. Completely, we have to understand, visualize, and the 3D model of the vaginal floor in our mind, how this floor is going and where the viscera is coming from the floor, what are the muscles, superficial muscles and the deep muscles, and how it is going around the all three structure. And usually we have to mark it before going for these operations. The major difference with the calpoperineorrhaphy and the lax vagina is that there is no basically rectocele. It is only a gaped vagina and little bit short perineum, which you have to repair. So we all know the indication, contraindication if she needs a future desire, active vulvovaginal infection or undiagnosed bleeding. So evaluate the patient. Detailed counseling session is required and documentation of the discussion is must before surgery. See for the psychosexual issue, as it is a purely cosmetic procedure on the demand of the client, a psychoanalysis to rule out any body dysmorphia and the sexual history is a part of evaluation. Without this, please don't do the operation. Why? This patient is not going to satisfied if she is having a body dysmorphia. And if she is having a pelvic organ prolapse, she is a candidate for the proper rectocele, cystocele repair, or if she is having an anal continence, proper anal sphincter repair. And you have to address these conditions. They are not the patient for the non-surgical rejuvenation at all. And plan the tightening also, because discuss with the patient, there might be a risk of over tightening also. There's a revision policy. You have to discuss all these things too with the patient. Now coming to the GSM, which is the second part where we really require a regeneration, because we all know because of the hyperestrogenic condition, there is an atrophy of the vaginal epithelium, and everything is shrinked. There's a genital sign such as dryness, burning, irritation, and the sexual symptoms such as discomfort or the pain. It affects peri and the postmenopausal women from 36% to 90%. There's a changes in the hair, the graying, thinning, and these are all three things of the genitourinary syndrome of the menopause is there. One term for the sexual symptom, genital symptom, and the urinary symptom. We have to remember the estrogen receptor, progesterone receptor, and the testosterone receptor, which are present. That's why in the vulval tissue, there's not much of the estrogen receptor. So inside, labia minora does not have so much of the vagina estrogen receptor, so atrophy does not occur. But the labia majora is full of the estrogen receptor. So with the age, labia majora shrinked and show like a empty sac. So here if you see there's a loss of estrogen, anatomical changes, functional changes, then there's a loss of collagen and elastin, there's a diminished blood flow, reduced elasticity, increased vaginal pH, and changes in the vaginal epithelial cells. Altogether, they lead to the vaginal problems in the older women. And here comes the role of the energy-based devices, which acts on the remodeling of the collagen neoangiogenesis and reversal of these problems inside the aging vagina. So we all know about this. I'm not going into the detail. So concept of the tightening the vaginal introitus, which has become lax due to childbirth and the progress with the aging due to the loss of collagen, is not a new concept. But what is new, why we are discussing today in last 8 to 10 years and more in the last 5 years in India, is non-surgical treatments which has come in terms of the energy-based devices and the adjuvants. So first it has started with the surgery, then energy-based devices has come up, and then role of adjuvants has come. Now it is you as a physician has to think what is the combination of the EBD and adjuvants you can give your patient, and patient is getting benefited by that. This decreased estrogen production during the perimenopausal period reduces the fibroblast activity, causing dermis atrophy with aged human skin and loss of the firmness. Water may promote injury or the infection. And it leads to the sexual dysfunction and the quality of life. And it is a common complaint reported by the perimenopausal women. So coming to the treatment using energy-based devices, when we talk about the energy-based devices, the most widely used are either lasers, or in lasers we have carbon dioxide laser, we have Nd:YAG laser, and then we have a radio frequency. So what is the basically mechanism? The basic mechanism is a heating of a connective tissue, and which causes the jump kyun kar raha hai? I'm so sorry, it is, I don't know why it is jumping today. So the efficacy of the laser therapy in the treatment of vulvovaginal atrophy has been suggested by the improvement of the GSM system. And for that, we have lots of score like VHI score, FSFI score, and we give the patient to full this FSFI score before the treatment and after the treatment. And added advantage is that you can offer to the post-cancer patient and remodeling tissue throughout the vagina. Basically, this particular diagram shows everything. There's nothing, just like you do the transvaginal sonography, you have to put this probe inside the vagina, and when you give the energy, it is a totally robotic arm. It starts rotating 360 degrees, and the laser beams goes all the side of the vagina and basically heats the collagen, which collagen after heating at the 40 degrees centigrade become the denatured and start remodeling. So carbon dioxide traction laser has been safely used, and it is a microablative laser, and laser beam is passed through the tissue in a 81 points. And what is it is like? It is like just like a small burning holes, like a burns, and in between the skin is normal, which causes a repair. And laser leads to a photostimulation, photodynamic reaction, and the photothermolytic actions. It is something in the deep side is going on the micro level, at the cellular level, which we are not able to see, but it has been described. There's an increase in the ATP, decrease in the oxidative stress, and mitochondrial level, there's a stimulation. So what happened when you give a laser? Basically, when you give laser, it needs a chromophore. Any laser needs a chromophore, and this chromophore in the vagina is a water. It absorbed it, some is reflected and some is penetrated. And this energy will automatically heat up the tissue. So in the phase 1, within 48 to 72 hours, there's an early thermal effect leading to the edema, release of the chemical mediators, shrinkage of the collagen and the elastic fiber. In the phase 2, in the following 30 days, there's a proliferation, fibroblastic recruiting, and new extracellular matrix. And phase 3, which is the third session, is a remodeling occurs. But one thing is very clear, your discussion with your patient should be there, because in the older age, how much effect it is going to give, it all depends patient physical health also. So never promise the 100%. Yes, most of the patient, they recover 60 to 70% and they are happy with it. So it causes a thermal damage, shrinkage, aseptic wound. So what happened when we see this normal tissue, it is a younger woman, there's a epidermis, dermis, and elastin fibers and the collagen fiber. And here in the older woman, there's a aging, obesity, degrades the vaginal tissue, normal collagen, and replace it with the abnormal tissue. After laser, it removes the upper tissue layer and new collagen grows from the inside, and it restructure and restore the vagina. So treatment protocol, it is an office procedure called the coffee time procedure. Come in and go. There's no anesthesia required, but if the patient is very sensitive on the outer introitus, which is the most sensitive area, we put the Pyrolox daily for 40 minutes. But you have to remove it properly before you start your laser treatment. 2 to 3 passes for the entire vaginal canal. But when we have become confident, many a time we give 4 passes also, 3 sessions, 1 month apart. And patient has to call with a 1 mammary session after a year, may repeat full course after 2 years. But some women, when we improve their physical health, they come after 2.5 years also. I cannot say, because my own personal experience is 3 years only with this non-surgical thing. And it needs a contraindication. All those things we can think of. Then the second thing is the radio frequency devices, the same action, and it can affect on your urethral support also, but it has to be very mild SUI. And another thing which we can treat as a mild cystocele. In that also laser has a wonderful effect. Although in the literature and in the conferences, people has shown the effect on the complete prolapse, but I have tried 1 or 2 patients, I am completely failed, and now I never offer to anyone to go with this thing for a really prolapse of 2nd degree or big prolapses. I don't think there's any effect. Maybe when I'll be more experienced, I have done more cases, maybe it will be possible, but those cases are reserved for the surgery. And for the vulvovaginal atrophy, you can offer those patients after 6 months of the surgery, non-surgical rejuvenation. So coming to the last thing, that is the regenerative adjuvants. I'm not going in the details because everyone is a detailed topic, but to introduce that PRP. PRP along with the EBD is a wonderful thing. Even it delayed the mammary session for 1 year, and patient's regeneration is much better. Here it is a autologous serum of the patient, and when we put it, because already when we do the laser, there is a micro needle like a small hole, so we need not to give any injection. The whole PRP is seep inside, and in the vaginal type, for the vaginal tightening, we can give the laterally PRP, and it really shrink the whole vaginal hole more than if we only do the laser. Then fat. Fat is a very, very wonderful thing as introduced. Usually we have to do the fillers, and fillers are very costly, and after 14 to 18 weeks, we have to do it again. But with the fat, it is for the longer time, patient's own fat. It is not going to go for any much extra cost. Usually we take fat from the love handles, and after making this fat with the nanotechnology, it will be introduced specifically in the cases of the labia majora augmentation, and wonderfully labia majora is formed and covered the whole of the labia minora. If you see your patient, if you in your OPD of an older woman or a patient which has a vaginal laxity, because of the labia minora is retracted outwards and they are not plump, there's a persistent gaping, and this persistent gaping of the vaginal canal on the lower side causes more of the vaginal dryness, and the chances of the infection increases. Now there's a role of stem cell also. I don't have any personal experience, so I can't say anything. Botox. This is one thing which is really a wonderful thing, specifically when not in the case of the vaginal laxity, but on the other side, when it is too tight to hurt, that is a vaginismus. Botox can be a good tool in our hand. Fillers, hyaluronic acid, totally it is a normal physiological thing, and never go for a fillers which does not have a hyaluronic acid in this area. They cause problem. Then implants has come, and specifically the threading. Like we use the bar suture in our laparoscopic surgery. Then the threads has come for the uplifting of the face, and these threads can be used in the vaginal tightening also. And within 3 months, they are dissolved, make a fibrosis, and they cause a real vaginal tightening. The question is that in future surgery, we don't know how they are going to affect. If we need to somehow dissect that vagina from the other plane, from the rectum, the future will only tell. And that is, I think, the major discomfort in the mind of our academician, our regulatory bodies, how to go about it. So coming to the last part, that is the vulval rejuvenation, which is almost not touched when we talk about the classical gynae practice. So vulva is the most visible female genital structure, but it has received the least attention, and you can say the forgotten pelvic organ. We should remember the vulval structure. Every single structure is important, from the mons pubis to the glands of clitoris, labia minora, labia intensa, labia majora, posterior faucet, prepuce. Because with the aging, there's a clitoral hood comes out, and you need a clitoral hood reduction. Then I have told you about the labia majora. Augmentation, only the augmentation can solve your many problems. And it is a different epithelium from the keratinized squamous epithelium to the squamous mucosa cover the vulva. So what are the common concerns when we talk about the vulval cosmesis? There might be pigmentation, hyperpigmentation, hypopigmentation, hairs, stress marks, and per se the vulval rejuvenation when we talk. It is a skin laxity, textural changes, dryness, itching, and episiotomy scar. We use PRP there, hyaluronic acid fillers for the labia augmentation. History, duration, other comorbidities, activity of the lesion, stability. We have to see everything, and always take a pap smear starting with anything if patient does not have a pap smear, and always discuss the expectation. Exclusion criteria are the same. These are the common lasers which are used for the different procedure. Then you have to discuss the concern, whether there is skin, dryness, itching, scars, medical pathology, and there's a aesthetic concern like improvement in the function, enhanced sexual experience, lack of sexual arousal. We have to see about the stretch marks and lasers along with the PRP. Really diminishes it. There are lots of creams also which can help to diminish it. So we have a treatment of options there. Patient is very aware today, and we have to discuss with the greater confidence, self-esteem. It affects the patient's self-esteem. Basket approach, complete package we have to deliver. Combination treatment. Daily skin care is important. Avoid fragrance or the color, synthetic or the tight-fitting clothes. Fractional carbon dioxide is no doubt a wonderful thing when we go about it, because there's a controlled tissue injury, neocollagenesis, collagen stimulation, improves skin texture in the endpoint. There is not charring when we talk about the fractional carbon dioxide. So convenience, we have to use adjuvant if we need. Here, hand face is a fractional energy 18 to 24 millijoule. Shape either full square, round, rectangle. I love the square. Passes 1 to 3, density 0.8, session 6. Hyperpigmentation can occur. So you have to be very, very careful. May start with the low energy. Gradually think about the comorbidity. Patient is PCOD, pre-diabetes. Those patients are prone to get the hyperpigmentation. You have to treat those comorbidities also. Don't go with a bigger energy because it can lead to the scar formation. And you can use with the PRP and the skin lightening criteria. Then micro needling radio frequency can be used. And these are the parameters for that. And it leads to a youthful glowing and a tightened skin. Can be combined with the other adjuvant again. So this is the PRP which I was talking with you. We use this platelet-rich plasma for many things. Simple non-surgical procedure, extremely natural, higher patient satisfaction, less downtime, works on the face and hairs also, and leads to the skin tightening. Procedure is that we have to apply a cream. Insulin needle is used to inject it, combining with a laser. Directly you can apply or a smear on the skin. Topical antibiotic you can give, results 2 to 3 weeks, session 2 to 3 every 6 to 8 weeks. Hyaluronic acid occur naturally and diffuse in the epithelial cells, bind 1,000 times. When you give, the 100% effect does not come with the over a time of 3 to 6 days. It plumps the skin, absorb the water. So we give a very, very small amount of the hyaluronic acid, not the much amount when we are giving it. So regional anatomy is very important to remember where to inject and where not to inject. Perivulval skin, dermal layer, subcutaneous layer, blood supplies. Always remember when you're doing specifically the labioplasty, because you have to maintain the labial circulation. Then coming to the procedure of this injection, we have to apply the anesthetic cream, needle 27 to 32 Gs, inject in the appropriate area, massage it. Otherwise, it will lead to a lump. Give a topical antibiotic, oral antibiotics, results is optimal in 21 days and quantity is 2 ml on the both side completely. You have to give a small amount in the whole area, divided into 10 parts. So these are the few pictures. So these procedures we can combine with the hymenoplasty, and all those plasties, specifically mansoplasty, is really necessary for many women because it comes like a bumps when you wear a tight jeans. So vulval varicosity is another thing, and I will not touch it at all because I'm not doing anti-aging at all, biological reversal, but it is a really latest thing and people are using it, and it itself is a great detailed lecture. But always remember the medical legal consideration, because fully informed consent is must. Clinician who perform FGCA must be aware that they are operating without a clear evidence. Women should be advised accordingly. You clearly tell them, and never take a woman girl below 18 years. So secret of change is to focus all your energy not on fighting old, but on building new. Thank you so much for your patient hearing.
Thank you, ma'am, for a very crisp take on vaginal rejuvenation. I just have one question to ask from you. That, as you rightly said, there is a lot of female genital cosmetic surgery is one of the most controversial topics, and most of the bodies, be it the New Zealand or the Australian society, the Canadian society, and even the RCOGs don't advocate this procedure. So not just this controversy, there's a controversy as to who's the best surgeon to perform it, because the dermatologists have the most experience with laser, the cosmetology is considered to be a forte of plastic surgeons, and gynecologists are more aware of the vaginal anatomy. So in your opinion, or according to whatever the evidence is, who's the best person to offer vaginal rejuvenation to a woman?
Actually, the thing is that we are the most giving person. We have given our everything on the plate to others, and we are just stick to the obstetrics and then to the medical indicated pathological gynecology. So everybody has taken everything. How a plastic surgeon can say that vagina is there? I think vagina is ours, and it is a high time when we reclaim it. And as far as the regulatory bodies, I don't know why they are so much against, when everything, I think somewhere we lack to, in our insistence, we are so busy. When a face can be operated, when the boobs can be operated, when the whole body can be operated, and it is taken in their fold, why not? If you ask me the laser, how many dermatologists are doing the laser 20 years back? And even at that time in the Dermatological Association, people, the senior dermatologists are saying this is a frivolous thing. What you are talking? I still remember my husband has started peeling for the acne. The very senior teachers, they have said, acne and acid? What rubbish you are talking? And today this is the most accepted method for the acne treatment and the scar treatment. So the thing will come. Even Professor, if you remember, in the laparoscopy, the Professor Kutsem was called a lunatic and asked to go to the asylum that he wants to operate with the laparoscope. And today, a doctor who is not using the laparoscope is considered not a surgeon. So I think somewhere it is our teachers who can take and start these procedures in the medical colleges. And when the medical college curriculum will accept it and start working, then it will get that level which should be given. Now urogynecology, talk about the urogynecology. The long time the urologist is doing everything, but it has accepted as a subspecialty, and we have lots of the urogynecologists. So time is not far off when it will, we have to take it back. I will say only this thing.
Thank you so much. Yeah, I think it was an excellent talk, and there's something new that we learned. It is a less discussed and a less known topic, and I think you really covered it beautifully.
Thank you so much. Thank you so much.
Ragini, that was, I'll just say one word. I have to appreciate you really went into the depth of it all and gave a beautiful talk. And like you said, for urogynecology, I think we should have cosmetic gynecology as one of the verticals of the main ops and gynecs. Just like you have the obstetrics, the gynae, the laparoscopy, the ART, this also could be one.
Yeah, Foxy is trying. Foxy is coming with the courses also. I think Foxy will be the first association in the world which has accepted cosmetic gynecology as a vertical. And I think we are going to have ICOG run courses also in that. And SARG is another association which has recently formed. Let's see.
All the very best. And I think you have us all quite glued to your talk, which is very nice.
Thank you so much. Thank you.
Thank you so much, ma'am. Your talk was really beneficial, and all the delegates truly benefited from your talk. Thank you so much. As we are going towards the end of the session, I would like to propose the vote of thanks. I thank Dr. Kanika Jain and Dr. Sonia Naik for planning and executing such an informative webinar on vaginoplasty, reconstruction to rejuvenation, I thank Dr. Achla Batra for sparing time and blessing us for this webinar. I thank Dr. Malvika Sabharwal ma'am from the bottom of my heart for sparing time and joining us this evening. I also thank Dr. Mala Srivastava for giving time to join us in this virtual learning. The star speakers, Dr. Ritu Arya, Dr. Hira, Dr. Hafiz Rahman, Dr. Ragini Agarwal, they have taught us a lot in their exhaustive, extensive, and very informative didactic scientific deliberation. I thank all the senior experts and discussants, Dr. Indu Chawla, Dr. Usha, Dr. Kanika Jain, Dr. Geeta Medirata, Dr. Sonia Naik, and Dr. Swati Agarwal for giving their very, very important inputs. I also thank AOGD and IAG Delhi chapter, the backend team for giving us seamless platform for conducting this webinar today, and most importantly, the delegates for joining us today, without whom no scientific program is complete. Thank you so much.
Thank you, everyone. And I thank all my seniors who are still logged in. That's really creditable, very encouraging for us. And I would like to also thank Dr. Manju Puri, whom I saw has been there with us since the beginning. And ma'am is still there. So thank you, everyone. Thank you, Dr. Sonia, and thank you, Ankita, for holding such a nice webinar. We'll have a part 2 of this for sure.
Thank you, ma'am.
Kanika, I must congratulate you for an excellent topic. The topic was very nice. Ankita, you conducted it beautifully, and thank you for just being in touch and turning all the links, etc. I must congratulate the whole team.
Thank you, ma'am.
Yeah, thank you so much, and Ankita, really a great breeze.
Thank you so
much.
much.
Thank you, Dr. Kanika. Looking forward to more association.
Ragini, really enjoyed listening to you. You know, somehow I always miss listening to your lecture.
Very topic and a nice.
Thank you, Ji.
Thank you.
Thank you, ma'am.
Okay, Ji. Bye-bye. Bye.